Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon. I'm the chair and organizer of Grand Rounds as we gallop into our 13th year of doing this. And I think it's now into our 5th year of doing this over Zoom as the COVID pandemic changed from us meeting at the Gannick Electric Theatre to us doing this in our offices and sometimes from home. This week, Kevin Fernando is going to talk about NAFLD to MASLD, what's in a name. We were just talking there briefly about how we know each other, and we're now so old we can't remember when we first met or what we were doing. But currently, at least, Kevin is a GP partner in North Berwick, but has other roles working with WebMD. He's an honorary reader here at the University of Dundee, and he's done a lot of work in the diabetes, cardiovascular risk sphere, as well as holding down a day job being a GP. So he wrote to me a little while ago asking if he could talk about NAFLD to MASLD. So looking forward to hearing his talk. As ever, if you have any questions, then please put them in the chat or hang on until the end when you can stick your hand up and ask in real life. So Kevin, thanks very much for offering to give the talk. Looking forward to hearing from you.
Cheers, Tom. And good afternoon, everyone. Thanks for the opportunity to speak at the Grand Rounds. So today what I wanted to do is take you through some recent change in terminology from NAFLD to MASLD. Non-alcoholic fatty liver disease has now been retermed MASLD, metabolic dysfunction associated steatotic liver disease. I know probably many of you are rolling your eyes straight away thinking this is the last thing we need, like a hole in the head in primary and secondary care. But actually, there is a clinical rationale here, and we've had recent updated guidance as well on the identification and management of MASLD presented at the recent European Diabetes Congress, EASD in Madrid, earlier on this month. So I wanted to take you through some key take-home messages from that, because this is a very hot topic for us all in primary and secondary care. Just last year, July, just over a year ago, liver organizations from across the world came together and had a consensus to rename NAFLD, as I said, fatty liver disease, to MASLD, partly to reduce the stigma associated with fatty liver disease, but also, more importantly, to help patient identification, help identify those at greatest risk of progressive liver disease. Okay, so I'll take you through some key take-home messages, and as Tom said, happy to take questions as we go along, and I'll make sure there's plenty of questions time for questions at the end. So thanks for your kind introduction again, Tom. Kevin Fernando, GP partner in North Berwick, very much still working as a GP partner part-time. Pretty much the rest of my time these days is keeping up to date. It's medicine, guidance, evidence is evolving at a terrifying rate, isn't it? I was speaking to one of my medical students recently, doing a tutorial actually, talking about the doubling of medical knowledge. So check this out. This is from a paper I found in 2016. In the 1950s, the estimated time of doubling of all medical knowledge, not just diabetes, was around 50 years. 1980s, estimated time of doubling of medical knowledge around 7.5 years. Fast forward, 2010, estimated time of doubling of medical knowledge just estimated at about 3 to 3.5 years. Fast forward again to around about now, 2020s. Anyone want to hazard a guess? Estimated time, Tom? Estimated time of doubling of medical knowledge currently estimated?
A week next Wednesday?
Yeah, it feels like that, doesn't it? They estimated it as 73 days, a time of doubling of all medical knowledge. And it does feel like that, as Tom's alluded to there. What I love and hate about a GP, being a GP, is I don't know what's coming in the door next, but the likelihood now is whatever does come in the door, how I manage it may have changed completely within the last 3 months. So, certainly in primary care, particularly, of course, we have guidelines coming at us for all clinical disciplines. And one of them indeed was this guidance on MASLD, which I wanted to take you through just now. These are my disclosures, but of course, today's an entirely independent talk. So I do work, as Tom said, for Medscape Global WebMD, very much as an educational role, creating content for both primary and secondary care. And again, just to illustrate the breadth of knowledge we now all require as doctors, nurses, pharmacists, dietitians, the whole MD team supporting people living with type 2 diabetes. A colleague, a GP colleague in Northern Ireland, and I co-authored this checklist, type 2 diabetes CVRM, cardiovascular renal metabolic checklist. Now, by no means I expect any of us to cover all of this in a single appointment, but I just wanted to again illustrate the breadth of knowledge we now require when supporting that person living with type 2 diabetes. Life story, lifestyle considerations, health behavior advice, of course, pivotal, not just to the management of type 2 diabetes, all long-term conditions. Individualized HbA1c targets, the kidneys, blood pressure, lipids, the heart, atherosclerotic cardiovascular disease and heart failure, obesity, living with obesity and overweight, the liver or MASLD, which is going to be a focus of today, airways, increasingly aware of airways disease, sleep apnea, COPD, and CVRM risk, prescribing considerations, MDT referrals, coding, and follow-up. So if you have some time, please do have a look at this. But I'm going to focus, as I said, on one section of this, the liver. And we had very recently updated a guidance published by the EASL, the European Association for the Study of Liver Disease, the EASD, European Association for the Study of Diabetes, and the EASO, European Association for the Study of Obesity. This guidance was just recently updated and presented at the EASD, the Diabetes Congress in Madrid last month, which I was fortunate to attend. And I found it a really interesting session, and I've tried to distill the key take-home messages relevant to us all as doctors, nurses, pharmacists, dietitians in primary care. But I thought it'd be useful, as always, to start with a case study, broadly based on one of my patients in North Berwick to hang our learning on. So this is Cara. Meet Cara. She's 52 years old. And she actually came to see me because she had some right upper quadrant pain, worse after eating. So my initial thought is, yeah, this is possibly gallbladder disease, gallstone. So I actually referred her for an ultrasound, an upper abdominal ultrasound. So when she eventually got quite a while later, of course, we're all struggling with waiting lists a wee bit at the moment. Actually, a common bile duct caliber was okay, but what it did show was that hyperechoic appearance of the liver, that common finding we see in primary and secondary care, fatty liver. So I thought I'd better have a look at some of her other numbers. So her blood pressure recently was 148/92. Her lipid profile showed that typical dyslipidemia we often see in clinical practice. A total cholesterol 6.3, elevated triglycerides 4.9, a low HDL 0.8, and the lab were unable to calculate her LDL cholesterol because of her high triglycerides. Her BMI recently was recorded as 33 and a waist circumference of 88 centimeters. And then look at her liver function test, or liver blood test, I should say. The bane of my life as a GP. My DocMan inbox is full of mildly abnormal liver blood tests. I never know quite what to do with it, so I just tick repeat 4 weeks and hope for the best. So ALT, slightly elevated. AST, slightly elevated. Alkaline phosphatase is okay. Gamma GT is slightly elevated. And a bilirubin is okay. Her HbA1c came back at 45 millimoles per mole, or in the pre-diabetic range. I prefer the terminology at risk of developing type 2 diabetes. Her renal function is thankfully okay. She's not on any prescribed medication by myself and my colleagues. She doesn't take anything over the counter, and she denies any illicit drug use or any herbal drug use, etc., herbal remedy use. In terms of her social history, she works as a tattoo artist in central Edinburgh. She's a non-smoker, and like many of my patients, she tells me she drinks alcohol socially. So, what do you think is the likely cause of our abnormal liver blood test? Could this be a chronic hepatitis C infection? We, of course, are underdiagnosed hepatitis C in clinical practice. Is this indeed MASLD, which I'm going to tell you a little bit more about? Or is this MASLD? So this is a new category. Again, I'll tell you a wee bit more about it in a minute, don't worry. This is a combination of both metabolic liver disease, but also alcohol-related liver disease. Or are you worried about something a wee bit more sinister, hepatocellular carcinoma? or do you think something else is going on? So any thoughts here? Feel free to type it into the chat box. And then the second question, of course, is what do you do next? What's your next step with respect to her liver tests? Do you reinforce that all-important lifestyle advice, focusing on weight loss perhaps, and revisiting alcohol consumption? Would you check a targeted liver screen? Would you phone a friend, refer to hepatology colleagues? Would you check a FIB4 score to assess any degree of liver fibrosis? And if you're not so familiar with that, don't worry, I'll take you through that just shortly. Would you look to do some more non-invasive imaging of the liver or assessment of the liver? Would you refer for liver elastography, FibroScan, or similar modality? Or would you try my usual dot man strategy and just repeat blood tests in 4 weeks? So again, if you have any thoughts, feel free to type them into the chat box or unmute yourself and talk. But what I wanted just to focus on first is telling you what MASLD is. This is probably the most important slide in my presentation today, the new definition. So NAFLD, as I told you, is now termed MASLD, metabolic dysfunction associated steatotic liver disease. So what the guidance defines MASLD as is individuals like my patient Cara, who has evidence of hepatic steatosis, but has at least one cardiometabolic risk factor. And we're all familiar with these cardiometabolic risk factors. So living with overweight or obesity, so a BMI over 25, or unfortunately for people like me, I'm stuffed on, I'm brought up in Scotland, originally from Sri Lanka. So a BMI of 23 and above is normal for me, or certainly minimizes my future cardiometabolic risk. A waist circumference of over 94 centimeters in men or over 80 centimeters in women. Of course, again, adjusted for ethnicity. So interestingly, in terms of diagnosing, classifying obesity, the European Association for the Study of Obesity recently recommend we use waist to height ratio to diagnose obesity, because this has been found to more closely correlate with future cardiometabolic risk. Compared to BMI, which is a fairly arbitrary measure, isn't it, of obesity, or waist circumference alone. But certainly in this guidance, they recommend these parameters, BMI and waist circumference. Next cardiometabolic risk factor, dysglycemia. So here they use an HbA1c threshold of 39 to 47, so 5.7% to 6.4%. And those are actually global US criteria for diagnosing pre-diabetes. In the UK, as you'll know, we use 42 to 47. Or, of course, the presence of type 2 diabetes. Next parameter, a blood pressure greater or equal to 130 over 85, or existing antihypertensive drug treatment. Then we have lipids, dyslipidemia. So either plasma triglycerides above 1.7 or lipid-lowering treatment, or a lower HDL cholesterol, less than 1 in men or less than 1.3 in women, or lipid-lowering therapy. So what does my patient Cara has? She has a full house, doesn't she, of cardiometabolic risk factors. She's got that hepatic steatosis, but she's got a full house of cardiometabolic risk factors. So she does indeed have MASLD. And then MASH replaces NASH. So many of you will be familiar. NASH is non-alcoholic steatohepatitis. So this is where you have inflammation of the hepatocytes in the liver. So that's now replaced by MASH, metabolic dysfunction associated steatohepatitis. Okay. And then we have this new category I briefly mentioned to you, MetALD. So MetALD, metabolic alcohol-related liver disease, describes individuals who have MASLD, but who also consume above recommended alcohol, amount of alcohol per week. So a combined etiology. So why this group of individuals have been segregated, what my hepatology colleagues tell me, these individuals can have quite aggressive and rapidly progressing liver disease, and in fact have a higher rate of mortality compared to those who have the conditions on their own. So that's why they've been categorized separately. So really, ladies and gentlemen, a key take-home message for all of us here today, MASLD is primarily a metabolic condition. It's not primarily a liver condition. It's primarily a metabolic condition, and it's the liver's manifestation of the metabolic syndrome. So if there's one message I want you to take away from today, That is the message, okay? So I'm going to come back to MASLD diagnosis management, but just a quick slide or two on abnormal liver blood tests. Very common, aren't they, in everyday clinical practice? And we do make a rod for our own backs, don't we? We often tick that LFT box. I'm often giving my GP trainees, medical students a hard time. Why are you checking LFTs or liver blood tests? Well, we need to challenge ourselves. What question are we looking to answer? Because the bottom line is, mildly abnormal liver blood tests are very common in primary care. And as we all know, the degree of abnormality doesn't always correlate, does it, with disease severity? Liver disease is often silent, isn't it, until quite advanced. And actually, when you look at the statistics, LFTs are often just checked for unexplained or non-specific symptoms. They're almost checked as a measure of well-being. And the bottom line is, of everyone listening today to Grand Rounds, 1 in 5 of us will have evidence of abnormal liver blood tests, but actually the majority of these individuals will not have underlying significant liver disease. So really, we must remember liver disease is relatively uncommon amongst those with abnormal liver blood tests in primary care. And what really hit home to me was a really interesting study published back in 2013 called the Ballot Study, a primary care study. So very generalizable to the patients I see on a day-to-day basis. They found 1,300 people in primary care with abnormal liver blood tests, but not known to have underlying liver disease. And what they found was only 2.5%, only 32 people out of that large cohort actually, or with abnormal LFTs, actually had a specific disease of the liver. So it just goes to show you how common abnormal liver blood tests are in primary care. But look at that, 40% of the whole cohort had fatty liver on ultrasound. And that's much higher these days. And I'll give you some updated figures in a minute. 8 malignancies were found. That's why often, certainly in primary care, we tick that LFT box to look for evidence of secondary or perhaps primary malignancy. And what about my usual dot man strategy? Repeat 4 weeks. Well, that's what they did in the study, incredibly. They repeated the entire liver function test panel every month for 2 years. And what did they find? Unsurprisingly, they found that LFTs remained persistently abnormal. So if you find abnormal LFTs, they're likely to remain persistently abnormal. So what the authors told us, rather than endlessly repeating LFTs, we should be more proactive and consider earlier investigation, a targeted liver screen, perhaps an ultrasound or other investigations to try and elucidate the cause of the underlying LFTs rather than endlessly repeating them. They did find some helpful facts for us, though. They found ALT and ALP, alkaline phosphatase, were most associated with significant liver disease. And they really echoed what we already knew about gamma GT, largely an unhelpful test, a very high false positive rate raised by obesity, certain drugs, and also, of course, alcohol. Gamma GT, very sensitive to alcohol intake. Really, the only time that I pay very close attention to gamma GT is the best predictor of mortality in those with established liver disease. And also gamma GT, on a more practical note, is very helpful to determine the cause of an elevated alkaline phosphatase. So if you see an elevated ALK phos, look at the gamma GT. If you have a high ALK phos and a high gamma GT, then of course think liver. Whereas if you have a high ALK phos and a low gamma GT, think bone and go down a sort of targeted bone screen. So really the conclusion of this study was liver disease is rare among those with abnormal LFTs in primary care. And then more recently, though, what I've read with interest was recent evidence suggests that our current upper limits of normal for ALT are too low, actually. And that's because we've underestimated the prevalence of fatty liver disease over the decades, which have driven ALT normal ranges. So the recent guidance I was telling you about, the EASL, the EASO, ESD, suggests now an individual should be considered to have elevated liver enzymes if their ALT is above 33 in a man and 25 in a female. Usual range 10 to 50. So I believe lab associations, National Lab Association is looking at pushing this across the UK. So watch this space. This might be something coming to your local lab very soon. And a really useful teaching tool if you're doing tutorials for colleagues, trainees, medical students. The British Society of Gastroenterology have produced this really useful flowchart, the response to abnormal liver blood tests. I use this on a regular basis for tutorials I deliver. It's open access. You can download it as a ready-made PowerPoint slide. So do have a look at this if you have some time. They provide a number of pathways, isolated raised bilirubin, a hepatic pattern of derangement of liver blood tests, etc., and give you targeted investigations to consider. So well worth having a look at this in your own time. But let's go back to MASLD, and I just wanted to just have a little prelude with LFTs there. So how common is MASLD? Well, MASLD is a ticking time bomb. While mortality from vascular disease, cardiovascular disease, respiratory disease, even cancer have fallen over the last 40, 50 years, mortality from liver disease has risen fourfold since the 1970s. And this has been driven by alcohol misuse, chronic viral hepatitis, particularly Hep B, Hep C, and now MASLD and MASH, driven by the obesity and metabolic syndrome. MASH is now tragically the most common liver disorder in Western countries, affecting up to a third of adults in the UK and up to 90% of people living with obesity or type 2 diabetes. So certainly that's where I first got my interest in MASLD, because of my long-standing interest in diabetes. Very common diagnosis alongside type 2 diabetes. And then MASH, the more inflammatory version of a stage of MASLD, affects up to 5% of the UK population and is now the fastest growing indication for liver transplantation in Western countries, again driven by the obesity epidemic. And type 2 diabetes and obesity themselves have the greatest impact on the natural history of MASLD. If you have both type 2 diabetes and obesity, you get a much more aggressively and progressive liver disease. So again, it's why we need to be aware of this potential significant comorbidity. And to be honest, this really hit home a couple of years ago in my own practice in North Berwick. We sadly, tragically had our first death from NAFLD cirrhosis in our practice. It was a young gentleman, only in his early 40s, a casualty of the pandemic, presented very late in the pandemic with a new diagnosis of type 2 diabetes, very high, triple-digit HbA1c, and also fulminant liver failure. He went straight onto the transplant list, but sadly didn't make it, and his cause of death on his death certificate was NAFLD cirrhosis, of course, before the new terminology. So again, it's something I think we all need to be aware of in primary and secondary care about the potential gravity of the diagnosis. And what I'm going to take you through is how we can identify those who are potentially modifiable, who have potentially modifiable liver disease. So MASLD is also associated with an increased prevalence and incidence of cardiovascular disease and is a risk factor for hepatocellular carcinoma. So I told you sadly about my patient who died. He did die of fulminant liver disease, but actually cardiovascular disease is a more common cause of death than liver disease in MASLD. So we need to be aware, assess cardiovascular risk, and try and mitigate cardiovascular risk in our patients living with MASLD. We've well established the safety of statins in people with MASLD, but individuals, data tells me, remain undertreated. There's no reason not to start a statin in someone with MASLD unless their LFTs are 3 times the upper limit of normal. Otherwise, do that Q-risk score, a SIME score, whichever cardiovascular risk score. If they are scoring high, start a statin unless LFTs are 3 times the upper limit of normal. So what is our role then? Well, if we can detect MASLD early, lifestyle change and certain other clinical interventions may slow or even halt progression of liver disease. And that's what I just wanted to spend the rest of my time telling you about. So I put together this little flowchart, the stages of MASLD. So the first stage I've told you already, MASLD, metabolic dysfunction associated steatotic liver disease. So this is where you have evidence of steatotic liver disease and at least one cardiometabolic risk factor. And as I told you already, unfortunately, my patient Cara is a full house of cardiometabolic risk factor. What I want to do is try and prevent Cara progressing from MASLD to MASH, metabolic dysfunction associated steatohepatitis. So this is where you have inflammation of the hepatocytes, and this stage is associated with fibrosis, cirrhosis, and even hepatocellular carcinoma, okay? And then after MASH, once you progress to liver fibrosis and liver cirrhosis, then of course these stages markedly associated with a marked increase in morbidity and mortality, and largely irreversible stages. So we need to be aware of these latter. So we want to try and identify people at these earlier stages to prevent progression to these latter stages. So this was a nice flowchart in the guidance that was just published last month, and I'm just going to walk you through this just now. Well worth diagnosing. It's an open access paper, the guidance. You can download this as a standalone figure as well, just to try and clarify in our minds how we diagnose these different categories of steatotic liver disease: MASH, MASLD, MET-ALD, and of course we mustn't forget about other causes: alcohol-related disease, drug-induced liver disease, and then cryptogenic steatotic liver disease, liver disease of no clear underlying cause. So let's walk through that algorithm with my patient Cara. Does she have evidence of steatotic liver disease? Absolutely. On an ultrasound scan, which I ordered for possible gallstone disease, does she have one cardiometabolic risk factor? She has a full house, as I've told you on a number of occasions. Also, don't forget about secondary causes of steatotic liver disease. So there are other non-metabolic causes of hepatic steatosis. Drug-induced liver injury can cause steatotic liver disease. So some commonly prescribed drugs that cause steatotic liver disease: amiodarone, steroids, very commonly used in primary and secondary care, methotrexate and tamoxifen. Certain endocrine disorders can also cause steatotic liver disease: hypothyroidism, PCOS, growth hormone deficiency, panhypopituitarism. Certain nutritional causes: parenteral nutrition, gastric bypass surgeries, bariatric surgery, or anorexia and other eating disorders. Chronic hepatitis C infection, and also celiac disease. So do be aware and exclude the presence of secondary causes of steatotic liver disease. And also remember, we need to revisit Cara's alcohol consumption. So the figures, the thresholds they give us in the guidance is over 20 grams a day in women, over 30 grams a day in men. If she's drinking above these thresholds, then she has MET-ALD, metabolic alcohol-related liver disease, that combination of MASLD and alcohol-related liver disease. If she's drinking above 50 grams a day in a lady, or 60 grams a day in a man, then my hepatology colleagues tell me that she has more pure, if you like, alcohol-related liver disease. So these are the thresholds suggested in the guidelines. So taking again a quick step back, what should we do in terms of considering screening for MASLD and MASH? I mean, what I did when I saw that ultrasound scan that I had ordered for suspected gallbladder disease, I saw that fatty appearance. So I did a full metabolic screen. So that's indeed what the guidance suggests. We should consider screening for MASLD and liver fibrosis. I'll tell you how to do that, either in individuals with type 2 diabetes, abnormal obesity and additional metabolic risk factors, or abnormal liver blood tests. This is what the guidance says. This has huge workload implications for us in primary and secondary care, doesn't it? So we can maybe pick up on that in Q&A. But the bottom line is, remember I said, MASLD is primarily a metabolic condition. It's not primarily a liver condition. And it's very common alongside these other cardiometabolic risk factors. So that's why we should have a low threshold for screening for MASLD. So how do we assess someone like Cara? And how importantly do we stratify a risk of developing advanced fibrosis? I don't want a second death from NAFLD cirrhosis in my practice. So we need to check BMI, waist circumference, as I told you, and blood pressure. So as I also mentioned, the direction of travel certainly recommended by the EASO, the European Association for the Study of Obesity, is assessing waist to height ratio, okay? We also need to check bloods, of course, to exclude other coexisting liver disease, if indeed she has abnormal liver blood tests, which she does, and other metabolic conditions. But remember, not everyone needs a full liver screen. Many of my colleagues are still checking coppers in ceruloplasmin. When was the last time I diagnosed Wilson's disease? Never. Last time I saw Wilson's disease was on an episode of ER in the late 90s. So not everyone needs a full liver screen. But what the British Society of Gastroenterology recommends as a minimum, perhaps, is hepatitis serology, of course, full blood count iron studies, HbA1c if they're not known to have type 2 diabetes, a lipid profile, UNEs, immunoglobulins, and autoantibodies, particularly to exclude autoimmune liver disease. So do consider a targeted liver screen. Of course, in younger individuals or those with a significant family history, you might want to check a copper or ceruloplasmin or other more rarer causes of liver disease. But for the majority, that is a good starting point. But really, the biggest change in my practice over the last few years is checking a FIB4, particularly in my higher risk individuals, to reduce the risk of advanced liver fibrosis. So if you're not so familiar with FIB4, very simple to calculate. We have a direct tick box in Lothian for it now on ICE, so it's very easy. I don't even need to calculate it. Age, AST, ALT, and platelet count, and it gives me a score. So CARA score is 2.08. So it's a bit like Q-risk or a sign, but for your liver. So it's assessing your future risk of developing significant or advanced liver fibrosis. So I'll tell you the significance of that 2.08 in a moment. So what the EASL, ESD, ESO guidance did is provide a really helpful algorithm on what to do with FIB4 scores. So this is the algorithm they provide. So walking you through from the top, in anyone with type 2 diabetes or anyone with obesity and one cardiometabolic risk factor, so that's my patient Cara, we should check a FIB4. So her FIB4 came back at 2.08. So that puts her in this intermediate category where further non-invasive assessment of a liver is recommended. So things like, depending on what you have access to locally, FibroScans, FibroTests. I don't have direct primary care access to these sort of investigations, so I have to refer to my hepatology colleagues. But what I can do, as you can see in the other part of the yellow box, is I can identify the management of her comorbidities. Once again, she has a full house of cardiometabolic risk factors. So I need to support her from that perspective. So she definitely needs further non-invasive assessment of her liver. Okay. This is our Lothian guideline on the management of asymptomatic abnormal LFTs in primary care. I know it's a wee bit maybe difficult to see on your screen, but we have an age-related cutoff. So for those under the age of 65, less than 1.3 suggests no fibrosis, whereas over the age of 65, less than 2 suggests no fibrosis. Whereas at all ages, over a FIB4 of over 3.25 suggests advanced fibrosis cirrhosis, strongly suggestive of alcohol-related liver disease. So those are the values I generally use. So CARA's 2.08 still clearly above that threshold that requires further assessment. Okay. So what can we do? I've said primary care, but this is definitely our secondary care colleagues listening in today. What can we do in primary and secondary care for patients like Cara with MASLD to lower her risk of advanced fibrosis? Lifestyle, of course, is pivotal. We need to strongly encourage and facilitate weight loss where possible. And the updated guideline I've been referring to throughout the presentation gives us some really lovely figures to share with patients like Cara, to share with our medical colleagues, to hopefully facilitate change. Weight loss of 5% reduces hepatic steatosis, reduces liver fat. Weight loss of 7 to 10% improves liver inflammation, reduces some of that hepatocyte inflammation we see in MASH. And weight loss of greater or more than 10% actually can help improve fibrosis. So these are very encouraging figures and show the positive benefits of weight reduction. So I routinely share these figures with patients like Cara to try and motivate change. Analogous, isn't it, to reversal of type 2 diabetes? The seminal DIRECT study, many of you will have patients recruited into the DIRECT trial. If you lose 15 kilograms in weight over 12 months, you have a near 90% chance of reversing your type 2 diabetes. Your weight loss of 10 to 15% gives you a significant chance of reversing your type 2 diabetes. So it's analogous to the remission story with type 2 diabetes. Interestingly, the EASL, the European Association for the Study of Liver Disease, recommends a Mediterranean diet, which many of our patients often follow, don't they? A Mediterranean diet, they tell me, can reduce liver fat even without significant weight loss. So that's something I may want to recommend to Cara. Regular physical activity in accordance with current government guidelines also can be helpful. Of course, alcohol abstinence is advised, particularly those with MASLD. But we all know what our patients say when we recommend cutting down on our alcohol intake. So we've got to be realistic, of course. But the party line from the guidance is alcohol abstinence, but certainly drinking within recommended limits. And then what I need to do is actively managing any coexisting features of a metabolic syndrome. So she has dysglycemia, doesn't she? Remember, her HbA1c was 45. She's living with obesity. So I'll refer her to our weight management service. She's got a borderline blood pressure. Her blood pressure was about 145, 89, I think, off the top of my head. So I'd want to reduce that. I think I'm probably very much focused on lifestyle first, but I'm going to have a low threshold to introduce perhaps an ACE or an ARB because of our overall cardiovascular risk. I want to manage a dyslipidemia. Again, I'll assess a cardiovascular risk and I will consider statin therapy for her as well. I tend to use the Q-Risk-3 score rather than a sign. I know a sign is Scottish, very generalizable to all the patients we see on a day-to-day basis, but a sign it has quite a narrow range of cardiovascular risk factors, whereas Q-Risk-3 has a much wider range. Things like severe mental illness. Delighted to see the fact that conditions such as schizophrenia, bipolar, severe depression with psychosis are now recognized as major cardiovascular risk factors. The tragic reality is, a patient of mine living with schizophrenia is likely to die 15 to 20 years younger than someone without schizophrenia. And the majority of this health inequality, this mortality gap, is actually due to common physical disease, such as cardiovascular disease and cancer. Sorry, I digress a wee bit. So I tend to use Q-Risk-3. If that Q-Risk-3 is above 10%, do consider statin therapy. Remember, there's no reason not to start a statin unless LFTs are 3 times the upper limit of normal. Okay, so do consider statins. Remember again, one of the leading causes of death in people with MASLD is indeed cardiovascular disease. And then finally, and I think you'll be amused to see this, many of you will be familiar with this, coffee. Coffee might help. Evidence has been brewing for many, many years now that coffee consumption has positive liver benefits. So finally, a vice of ours that is actually good for our health. So what the guidance tells us from last month, in adults like Cara with MASLD, coffee consumption, interestingly, caffeinated or decaf coffee, has been associated with improvements in liver damage and reduced liver-related clinical outcomes. So there's no clear recommendation on quantity, but the figure that I seem to keep picking up in various articles about coffee is 3 cups of coffee a day. Seems to have a positive liver impact. And I've definitely seen that in some letters from my hepatology colleagues for patients with the liver disease, recommending they increase their coffee intake. So I thought that was really interesting. And certainly the British Liver Trust have published a report back in 2016. It just shows you how long this evidence has been brewing for, telling us about the positive health benefits of coffee and the liver. So do have a look at that if you have some time. So just coming to end now, just a little bit about follow-up and then a little bit on future directions of management, some pharmacological options. I hope you've noticed I've not mentioned anything about medication at the moment, or very little. Very much we need to focus on lifestyle. So how do I follow up Cara? Well, of course, I need to make sure that Cara is under regular follow-up. I need to code her accurately with MASLD, and I need to put her under recall, as I would do with anyone with a long-term cardiometabolic condition, because she is at intermediate risk of advanced fibrosis as governed by that FIB-4 score. So I need to review her regularly in primary care using my clinical judgment and local guidance. So that frequency of follow-up, of course, is down to me to discuss. So what do I need to do? As I said, we need to reinforce lifestyle modification, focusing on weight loss. I've referred her actually to the weight management service. And I want to revisit her alcohol consumption as well. Make sure she's drinking within recommended limits, ideally alcohol abstinence. I need to look at our other features of metabolic syndrome and aggressively manage those. And as mentioned, look at a cardiovascular risk and consider statin. And I need to keep a regular eye on a FIB4 score. Of course, I need to wait for the result of a FibroScan, but what that updated guidance gives me is not only what to do with that initial FIB4 score, but how to follow up that FIB4 score. So say her FibroScan is reassuring, I need to reassess that FIB4 score after at least a year, depending on her risk stratification. And again, I'll take a steer from local guidance here as well. So do have a look at this if you have some time. So finally then, before I close with what I did for Cara and my key take-home messages, there are some emerging pharmacological treatments for MASLD and MASH. Now, I should point out in the UK, there are no current licensed drug therapies for MASLD or MASH. But just this year, earlier this year in the US, resmetirom, brand name Resdifra, is the first MASH-directed therapy to be approved by the US FDA and should be considered for the treatment of non-cirrhotic MASH with significant liver fibrosis. So resmetirom is actually an oral drug. It's actually a thyroid hormone receptor agonist. Please don't ask me how exactly it works in the context of liver disease. That's a bit beyond me. But it's the first MASH-approved therapy for a license in the US. So it will be coming to the UK probably next year. But I suppose what you've probably heard more about and what I definitely have much more experience on are the compelling and emerging evidence for the incretin molecules or the skinny jabs that all our patients know about on our sourcing on eBay and all sorts of other dodgy online sources. So we have compelling evidence for tirzepatide or Mounjaro, which has been available to us in the UK since February, has an SMC for both type 2 diabetes and also obesity. But we had a recently published trial for tirzepatide called Synergy NASH, which showed positive benefits for fatty liver disease. Just published, these 3 studies I'm showing you here were published just in the last couple of months. Then we have a triple agonist. So sorry, I should point out tirzepatide, if you're not familiar, is what we call a GLP-1 and a GIP. So many of you will be familiar with GLP-1s, glucagon, certain-like peptide 1 receptor agonist. So that's your drugs such as semaglutide or Ozempic, or dulaglutide or Trulicity. These are once-weekly injectable drugs. Tirzepatide is also an incretin molecule. It's a once-weekly injectable drug, but it's a combination of GLP-1 hormone and another gut hormone called GIP, glucose-dependent insulotropic polypeptide. It's another gut hormone that's released in response to food, to a glucose load. And what that does is stimulates the pancreas to secrete insulin, but it also slows gastric emptying, making us feel full, and it also passes into the cerebral circulation and has a direct impact on increasing satiety and making us feel full. So that's how it has an impact on losing weight. But we also have triple agonists coming. Some of you will be familiar or heard of a drug called retatrutide. It's a triple agonist. So it's GLP, GIP, and a glucagon agonist. And that also has some very recent published data, compelling data for steatotic liver disease. And finally, another dual drug, incretin, survodutide. It's a GLP-1 and a glucagon agonist. So I know these are just horizon scanning. They are not available now, but I just wanted to give you an idea of what is coming in the not too distant future. It comes back to that doubling of medical knowledge I started off with. So there is emerging and compelling evidence. But actually, the updated guidance I've been referring to currently tells us there's insufficient evidence to recommend SGLT2s, incretin mimetics, or indeed pioglitazone as MASH-targeted therapies. Part of the reason is this: all those studies were only published in the last few months. So I'm guessing after they did the literature search for the guideline. But pioglitazone I was surprised with, because pioglitazone, good old diabetes drug, I know not without its issues, but one of its key advantages, it directly tackles insulin resistance and has been demonstrated to have improvements in liver disease. And the nice NAFLD guideline, albeit quite old now, does recommend pioglitazone use in people with and without diabetes. So I was surprised to see they didn't recommend pioglitazone. It certainly remains part of my armamentarium to manage fatty liver disease. So Tom, I'll finish up there now, coming back to Cara, and then with some four key take-home messages for everyone. So what's the likely cause of abnormal liver blood tests? Absolutely, likely MASLD, though I do need to revisit her alcohol intake. What's my next step with respect to a liver blood test? Lifestyle advice, reinforce weight loss. I'll refer her to the weight management service. She's open to that referral. And again, revisit alcohol intake. A targeted liver screen to exclude other coexisting liver disease. And it was actually clear. I told you that her FIB4 score was 2.08. So she's at intermediate risk of future fibrosis. So I've referred her to my hepatology colleagues for second-line non-invasive testing, FibroTest, FibroScan, ELF, etc. But meanwhile, what I'm going to do in primary care is actively manage her other features of metabolic syndrome, her borderline blood pressure, her dyslipidemia, etc. Her QRIS-3 score is only 4.5. She is only a young lady, so what might be more relevant for her is lifetime risk rather than 10-year cardiovascular risk. But nevertheless, we opted not to commence a statin and to try and focus on lifestyle intervention, weight loss. And I've suggested she might want to step up her coffee intake. She's not a big fan of coffee, but she said she might try and introduce a cup or two a day if she can. So here are my key take-home messages for you, ladies and gentlemen. MASLD is primarily a metabolic disease. It's not primarily a liver disease. It's the liver's manifestation of the metabolic syndrome. We, as clinicians, as GPs, nurses, doctors, pharmacists, we need to consider risk factor stratification for all those with suspected MASLD with liver fibrosis markers. And the marker recommended in updated guidance is the FIB4 score, fibrosis 4 score. And in terms of management, aiming, ideally, mutually agreed target of 10% or more can actually help improve liver fibrosis. But actually, as I told you already, weight loss of just 3 to 5% can reduce hepatic steatosis. And finally, there are no current licensed therapies in the UK for MASH, but resmetirom is licensed in the US, will be coming to the UK next year, and we have emerging and compelling evidence for incretins, and coffee might help. So I'll finish off with a couple of resources I've put together. So again, with my Medscape global hat on, I've put together one sheet on identification and management of people with MASLD and MASH in primary care. Just going through much of what I've taken you over the last 45 minutes or so. So again, feel free to have a look at that in your own time. And then I know many of you will laugh, but I actually have a YouTube channel. My kids are mortified. They've all unfollowed me online. In fact, to be honest, they've all unfollowed me in real life too. But I've done a lot of patient-facing videos. They're all 3 or 4 minutes. I've done some about medications such as SGLT2s, but the big bulk of them are lifestyle for patients like Cara, talking about various lifestyle interventions. So if you have some time, please do have a look at those. And happy to take any questions or comments now. Happy to share the slides if you'd find that helpful. Here are my contact details. Thanks for listening, everyone. And Tom, thanks for giving me the opportunity to deliver today's grand round.
Thanks very much, Kevin. That's fantastic. Because the liver is an organ that's below the diaphragm, so I know very little. So that's an excellent update for me. And I was aware that all the acronyms had changed and all the letters were moving around. So that's just really, really helpful, pragmatic review of what to do in the real world. There's no questions in the chat, but if anyone has a question they want to stick their hand up, we've got eminent diabetologists and hepatologists and all sorts. And hiding in the dark is Rory McFinn.
Yeah, Tom, I'm hiding in the dark because there's so much sun up in here in Dundee at the moment. I'm having to close the curtains.
Dundee is Sunday, as you know.
So Kevin, look, thanks very much for the talk. Very interesting. Just as a point of information for you here, a gastroenterologist in Dundee called John Dillon developed a thing called the intelligent liver function.
Yes. Yeah.
In primary care, almost all abnormal tests are diverted down this pathway. The question is often, what threshold do you choose before you get to that? But I think we've found that really helpful. One thing I wanted to pick up on you was around body mass index.
Sure.
Because I think I see a lot of people in the clinic whose body mass index, particularly, I mean, I'd say from South India or from the Far East, where you can have a body mass index from 23 to 26 and yet still have quite abnormal LFTs and fatty liver. In which case, something like a GLP-1 receptor agonist is a very logical therapy. And you mentioned weight to height, but again, is that being looked at in different groups, or is it still based largely on sort of white Caucasian population?
Okay. So I was chatting with our mutual colleague Jason Gill about this, and he and Naveed Sattar as well. So a lot of the studies are still, of course, in largely Caucasian populations, but I mean, I think it comes down to that whole personal fat threshold theory, isn't it? And we all have a personal fat threshold. The Retune study was a great type 2 diabetes remission study by the legend Roy Taylor that demonstrated you can reverse type 2 diabetes even with people of a BMI less than 27. Essentially, we all have a personal fat threshold. So I think that's why we see so much variation, particularly in higher risk populations like my original ethnicity. So I think certainly a measure of abdominal obesity rather than BMI, so waist circumference or waist to height ratio is much more helpful. Certainly, Jason Gill does show me that the evidence base is expanding. He's had a few recent publications as well, validating a lot of these indices in higher risk populations, which is reassuring. But there's still a way to go. Unfortunately, ethnic minorities remain underrepresented, don't they, in a lot of these clinical trials. So there's still quite a bit of work to go here.
Yeah, a follow-on question, if I may, Tom. I mean, I think obviously in diabetes care is now dispersed between primary and secondary care. But if I look at routine screening, we don't actually routinely measure liver blood tests or full blood count, which makes, therefore, the calculation of these scores quite challenging within the situation. In fact, we're not measuring anything beyond BMI either. Is it time, do you think, that we begin to change what we're actually doing on a routine basis between both primary and secondary care and diabetes?
Yeah. So I think we have to be careful here because I spent the beginning telling you we over request LFTs in primary care, so sort of stuck with a rock and a hard place. The BSG, the British Society of Gastroenterology, take a more pragmatic approach, certainly in the context of type 2 diabetes, and this is what I'm doing with my practice nurses in North Berwick, are higher risk patients, so just 50 young age, so over 50 type 2 diabetes living with obesity, we're routinely doing a FIB4 score. So I suppose we're taking a target, for a higher risk patients. But certainly, LFTs are not routinely done in a type 2 diabetes review for everyone. We've been trying to rationalize requesting of type 2 diabetes, but as you've alluded to, with the increasing prevalence of MASLD and significant associated liver fibrosis, maybe it's time to revisit that. But at the moment, there's certainly no evidence for universal screening. That's quite clear. There's no evidence currently supporting universal screening with LFTs for all. So I'm taking a more targeted screening approach for my higher risk patients in primary care.
Great, thanks, Kevin. I'm sure other people want to come in. Otherwise, I'd just carry on.
In the comments, Kevin, Steph Sim.
Oh yeah, we went to uni together. Yeah.
There you go. Well, she's in the audience and says it's great to see you.
Hi, Steph. Lovely to see you.
It's been a while since FYC 2000.
Yeah, I know. Gosh, 24 years. Hard to believe.
There you go. And good news about the coffee. Damien Leith says, if only there was some sort of intelligent diabetes care platform that could do all of this. I presume that's an insider code.
Sorry, Tom, that's iDiabetes. So Kevin, just to let you know that, and you and Pearson is obviously leading on this in Dundee, yes, along with myself, John Dillon, and Chim Lang and a few others, and Samira Bell in renal, but effectively we've created an electronic platform for everybody with diabetes in the community. And they're going to be randomized into standard care or into this new iDiabetes platform where they will be directed down this exact route in terms of determining what is the most appropriate therapy. Because as you know, one of the challenges we face, Kevin, is you could almost randomize practices into their choice of first and second line agent, for instance, of oral treatment for diabetes. Yeah. Whereas for individuals like this, although there is no strong evidence for MASH, undoubtedly you're going to prefer a GLP-1 receptor agonist, of course, or probably an SGLT2 inhibitor, along with metformin, as opposed to, say, a sulfonylurea. And so this is the type of decision making that would happen.
Well, great.
Right, lovely. 4 minutes until my first patient in clinic, so I'll draw things to a conclusion. Kevin, thanks very much for reaching out and offering to give the talk. Enjoyed it very much. Thanks everyone else for your attendance today, and I will send on details of next week's Grand Round in the next email. Thanks very much again, and enjoy your weekends.
Thanks everyone. Take care. Cheers.